Yes, I think it's great, and it's great that somebody speaks about the pain. And in a lot of countries, everybody speaks about the level of treatment, but nobody speaks about the pain. The pain is a central thing. Why? Because the parents, you have a kid who have a pain. It is the most important thing in your life, because your kid have pain. This is the problem. And I think it's great. The session was great.
Pain management remains an important topic for many people with hemophilia and with other bleeding disorders. And today was an interesting day to have views of different techniques to use. And for me, the most important was to know what is the most precise and the most interesting thing for each patient, to help people with bleeding disorders. But I think we will have to keep an eye very strong about this field in the future.
Hello, my name is Nathalie Roussel from Belgium.
My name is Paul McLaughlin, physio from London, and we've both been attending the EHC roundtable today in Brussels on pain management. So we've been asked to have a think and a discussion around what we have, our take-home thoughts from the presentation, and I think mine would be the amount of questions in the room directed to the physio, and the fact that lots of people are very excited or can see the value of physio, and maybe from our presentations, but perhaps that the statistics for patients' availability for physios doesn't match the potential.
No, in your presentation you said that only 29% of patients were doing physical therapy as treatment, and I think that we are all convinced that physical therapy has a place in the management of pain of patients with hemophilia. Do you have an explanation for the lack of attendance to physical therapy?
I think it's a complicated issue. Perhaps the historical narrative of haemophilia has been it's been a predominantly medical problem, so predominantly medical issue, and so that the focus of intervention was around treatment for the bleeding. But obviously we deal with patients who have had bleeding, are on prophylaxis, and who don't experience a lot of bleeding but experience a lot of joint disease and pain.
Yeah, it's important to mention that the physiotherapy has evolved also over the years. Physiotherapy of now is not the same as physiotherapy 20 years ago, and maybe patients might have bad experience or not positive experience of physiotherapy 20 years ago, and that's the reason maybe why they are not attending physio practices now?
And possibly maybe the availability.
What are the challenges for the next 10 years for you as physiotherapist specializing in hemophilia?
I think, having sort of heard some people talk and read some papers, that the funding issue for centres generally, where funders continue to focus only on medical treatment, and medical treatment gets better and people bleed less, then there's less money available for staff to help with the other bits that aren't related to haemophilia. What do you see as the opportunities and the gaps in our knowledge?
Yeah, I think there has been a tremendous evolution in the care of patients with joint pain, non-hemophilia related, and I think this insight can be translated, can be checked in patients with hemophilia. I think that, for example, the use of explanation of pain, the contributing factors, but also the use of physical activity as a way to decrease pain is one of the options for the next years. But I really think that physical activity should be coached by, for example, physical therapists, because you need a dosage of physical activity before you get this decrease in pain. And this is an individual treatment plan that should be discussed together with the patient. You are familiar with the shared decision concept,
yeah.
But I think in hemophilia it's not always used. But if there are more than one medical options, then it should be discussed with the patient. And so this individual treatment plan for each patient should be further developed, and also leave those myths that pain is linked to damage, or pain is always linked to bleeding when it's a kind of a increase of pain sensation. These myths are not helpful, and patients should be aware, but also the healthcare providers, because I think that pain is not well known by many clinicians dealing with hemophilia, and that they will benefit from really pain courses for healthcare providers so that they have the same talk to the patients. We spoke also about comprehensive care, but if different healthcare providers have different message to the patients, then it will not be very helpful for the patients.
I totally agree with the comprehensive care aspect, and I think one thing that perhaps may get lost in some of the conversations is that any physio is okay for the patient with haemophilia that has pain, and for some patients that may be fine, but the advantage of having a physio who understands that person because they've known them
For years.
And they understand haemophilia and they understand the treatment of haemophilia and the evolution of the treatment, that actually being able to coach and help someone with the activity means that you are there with your knowledge as a physio, but you're there with the knowledge of haemophilia and the knowledge of that person. And I think that's the magic, part of the magic ingredient of how we should move forward, and the fact that I strongly believe that patients within a haemophilia centre, in the same way they have a named haematologist, they should have a named physio. It should be someone who works with them and understands their disease. If you have not done activity for 20 years and we start you on a new activity, this is normal. You have good pain, if there is such a thing, but normal activity-related pain, which if you push on past that, it will get better and things will improve. And that's a very unique conversation with the person.
Yeah, I perfectly agree, and one of the aspects in research that has been overlooked is the adherence. If a patient is not adherent to treatment, there will be no treatment effect, and if you know the patient very well as physiotherapists because you've followed them for many years, you can discuss this adherence to exercise or to physical activity with the patients, and this should be really discussed with the patients. The fact that they are doing the treatments, and if they are not doing it, that we search for another option. There are many options that are possible, but we have to discuss it with the patient.
Yes, and I think there's a clinical